Yeah, so welcome back to this live surgical session and this historic Isocon. How Dr. Rajiv Pachori has done everything to make it the most successful one. We all know, and this is a important session again. So today we are going to run till 7 o'clock, as we have a very important, I would say, session after that, Javed Ali night. And tomorrow morning till evening again we'll be back with some interesting cases. So thanks to the Isocon organizing team, and I again welcome you on behalf of the Isocon to this live surgical session. Big thanks to our chairman Dr. Ravi Ramalingam, who has made this Isocon I would say a huge brand wherein the academic is prevailing and a lot of new thoughts have been exchanged every time with the foreign faculty and other elite faculty members. So thank you once again for this joining us. So in today's session we have 3 hours, I would say. It's already 4:15 or so. So we'll be starting with the basics with the internal tympanoplasty, and then after that we'll be doing one cochlear implant. The aim of this session is to incite more and more interaction to benefit each other. And believe me, I am the one who is going to be benefited most out of this discussion. Every day, being doctors, we have to learn more and more every day. So I request everyone to be participating actively with their thoughts, ideas, suggestions, questions, queries, whatever, to make it more and more interactive. So tomorrow, after this, today we are doing 2 cases, looking at the time scenario, tympanoplasty and cochlear implant. Tomorrow we have more advanced cases, more variety of cases. Listen now. So tomorrow again we'll be having cochlear implant for some malformation, IP malformation, incomplete partition. Then we'll be having some stapes cases, interesting ones. Then we'll be having paraganglioma. Then we'll be having surgery for malignant otitis externa, a sort of subtotal peterochectomy. This is one of the most, I would say, difficult to treat kind of a problem, which is a challenge and I would say a most difficult life for the surgeons as well as patients. So tomorrow we have a case for malignant otitis externa, and we'll discuss in the present scenario what best can be done for those poor patients who are suffering with a problem which is considered to be so difficult to treat. Then we have cholesteatoma cases. Then we have Peter's bone cholesteatoma, something we discuss in our theories lectures, but at the conference time sometimes we get with difficulty. So tomorrow I have purposely kept a case of huge temporal bone cholesteatoma, Peter's bone cholesteatoma, involving the entire Peter's bone, making all the parts of the carotid dehiscent, pushed, inner ear, destroyed, carotid post compressed, and the entire hearing, facial nerve, everything gone, and the entire temporal bone, almost entire temporal bone is replaced by cholesteatoma to deal with those situations which are otherwise life-threatening issues. Then we have cases for facial reanimation and some other otology cases if the time permits. From tomorrow 8 or 9, what time Dr. Pachori dictate us, and since today we have a huge Javed Ali night, so I don't think we'll be able to we'll be prepared for 8 o'clock beginning or maybe 9 o'clock, whatever, till 5 o'clock in the evening we'll be doing all these cases. So again for tomorrow, stapes surgery, cholesteatoma surgery, surgery for malignant otitis externa, Peter's bone cholesteatoma, again would be a obliteration, then paraganglioma, then facial reanimation. So all a variety of cases to discuss more and more in this prestigious conference to try to complete our discussion regarding more and more complex problems in otology and lateral skull base surgery. So To begin with, a basic scenario, tympanoplasty. We all know we have been doing tympanoplasty. I think everybody attending has been doing tympanoplasty for long, and we all know tympanoplasty has excitingly good results, but still not 100%. Like in any surgery, we can't achieve 100%, and we are thriving more and more to achieve that. And this happens to be the most common surgery in otolaryngology, we all know, wherein clinically we get a perforation. It looks so simple every time when you look at the perforation too, and it makes us to repair it mechanically. And many a time, in spite of the best effort, it doesn't work, and ultimately, unfortunately, we may have to see a failure. So still, there are things to be discussed in tympanoplasty to make it more and more, better. And out of my experience, what we have been doing here for years together, the technique we have been proposing is the interlay technique, which I learnt in 90s from Professor A.B.R. Desai, and we did modify also after that. And looking at the current time scenario, what we have been doing, I am going to propose it today. So tympanoplasty, the name looks simple. People call it myringoplasty as well, just repairing the tympanic membrane perforation. But believe me, it is not as simple as we call it repairing. It is the outcome of pathology in the middle ear cleft. We all know middle ear cleft is comprised of mesotympanum, eustachian tube, and the mastoid air cell system, all having the mucosa which has a capability of secretion and drainage, is served by the middle ear cleft. The entire middle ear cleft contains that kind of mucosa. Disease anywhere in the middle ear cleft can present ultimately with a perforation, or a perforation in the tympanic membrane can cause other problems in the middle ear cleft if long standing. So the time is to address the entire middle ear cleft. Why we are discussing? We all know by any means you do myringoplasty, tympanoplasty, it has a excitingly good results, I would say about 90%, 95%. Still, we are not getting desired result in every case. So we have to look at the causes of failure. The things which are beyond our control, obviously we cannot do. But things which need to be addressed, we have to discuss more and more. So our technique, what we propose is looking at the entire middle ear cleft. We need to look at the eustachian tube, we need to look at the mesotympanum. I will address that surgically and discuss. And the mastoid air cell system, which is dependent upon the aeration down the eustachian tube. And how this system is so complex, you can imagine from the fact that every time we swallow, how the God has given us this unique physiology of the ear. Every time we swallow, the eustachian tube opens, and air which is contained in the isthmus part of the eustachian tube. The middle nervous segment is isthmus. Whatever air is contained in the isthmus is driven into the middle ear by every swallow. The cartilaginous eustachian tube in the nasopharynx opens, and that drives the air from the isthmus. Not the entire air from the nasopharynx is driven every time. Only that air contained in the isthmus is driven into the middle ear. And middle ear has a natural physiology of resorption of air. So middle ear mucosa continuously absorbs the air. When the threshold of the middle ear pressure declines, the eustachian tube opens and drives the air inside. This is how the physiology is maintained. So every time we swallow, the air is driven into the middle ear, and it equalizes the pressure between the middle ear air and the atmospheric air. And the amount of air which is driven every time is 2 microliter. 2 microliter, that is the volume of the isthmus, it is driven every time. So the entire physiology of the ear is dependent upon the eustachian tube, what I mean to say. So in any given situation, in long-standing chronic diseases of the ear like central perforation, whatever aticoenteral disease, we need to look at the eustachian tube function primarily in terms of thinking at the long-term results. You know, if we ignore all this, whatever tympanoplasty you do primarily has more than 90% good success rate. Whatever published series you see, many of the series even, you know, say about 98%, 95%, whatever they claim. No long-term series, long-term means results 10 years down the line, has claimed more than 70 to 80% results in spite of the best of the center and the best of the surgeon and best of the results. The reason being the physiology. We are lacking to address the physiology, and that in terms of otology practice, this physiology is affecting the eustachian tube. Any nasal problem may affect the eustachian tube and ultimately ear may again suppurate. Why ear problems are happening? Not de novo, because of the long term or whatever childhood eustachian tube issues. So we need to address the eustachian tube issues later on also post-operatively. In pre-op setting, it is difficult to ascertain the function of the eustachian tube. We all know. What we can ascertain is mechanical, function of the eustachian tube. But what we need to ascertain is the functional ability of the eustachian tube. Hi, Ashish. Hi. Yeah. So Ashish, we just started discussion. Today we are doing two cases. I am beginning with the basic, the tympanoplasty, and then we'll be having cochlear implant. Tomorrow we'll have a lot of advanced cases: subtotal pterygiectomy, malignant otitis externa, Peter's bone cholesteatomas, and malformed cochlea, facial nerve, and other cases.
Based osteomyelitis you having?
Yes, tomorrow.
Yeah, tomorrow. Okay.
So what we are discussing about in otology, whenever we look at the ear, we must ascertain the eustachian tube function. That is most important. In reality, ascertaining the eustachian tube function is very, very difficult. What we can, at the highest level, what we can do clinically is ascertaining the ventilatory function of the eustachian tube. Out of two functions, eustachian tubes have two functions. One is ventilatory function, another is secretory function or mucociliary activity. Mucociliary means whatever mucus secreted in the middle ear and the mastoid air cleft is propelled down the eustachian tube into the nasopharynx. That is a property of the ciliary activity of the mucosa and the eustachian tube. If eustachian tube has a malfunction in this ability, the ear cannot survive. Like for example, if patient has a generalized ciliary defect because of many reasons, like in bronchiectasis or other regions, cartilaginous syndrome, if the ciliary activity is at fault, whatever tympanoplasty you do, it can never be a successful one because that mucociliary activity cannot be served adequately. Similarly, the ventilatory function, which is more important. That's why I was emphasizing on this ascertaining the ventilatory function is, whenever we see in our clinical scenario, see a central perforation, we are immediately start thinking of doing a tympanoplasty without looking into the nose, without looking into the eustachian tube, and start thinking mechanically to repair the eardrum. And that's why in all cases we do not get desired results. So we need to look into that. This is the need of the time so that we can increase our success rate. If you remember the 100-year-old dictum, before look into the ear, we must look into the nose. And this stands true. There are many nasal pathologies which can affect the eustachian tube. In rhinology conferences, we always discuss this chronic rhinosinusitis, allergy, adenoid that can affect the eustachian tube, and ultimately we so commonly found otitis media with diffusion and otitis media, particularly in the pediatric age group, which goes on in adult and persisting as a perforation. So if we look into the nose, this is the need of the time, and we must spend some time before taking up any case for tympanoplasty to look into the nose. And secondly, the simple ventilatory function, which I suggest you, everybody is having a tympanometer and one can easily do that test with the tympanometer. The reason being, the most important function which eustachian tube serve is ventilatory. As I said just now, every time we swallow, the eustachian tube opens and it drives the air in the isthmus of the eustachian tube into the middle ear to equalize the air pressure. So this ventilatory function should be good for the ear to function adequately after the surgery. Otherwise, whatever surgery you have done can go waste. So how to assess this? Simply by means of a tympanometer. What does tympanometer do? By tympanometry, you close the extra-auditory canal by the tympanometry probe. And then middle ear has only one outlet for the air to go outside, that is eustachian tube. So in tympanometry, there is a pressure manometric pump. Once you attach or seal the extra-auditory canal with the tympanometry probe, we can manually raise or reduce the pressure with the manometer into the ear and the extra-auditory canal, middle ear and the extra-auditory canal, positive or negative, whatever. That is done mechanically by us. And then ask the patient to repeatedly swallow. You can see on tympanogram if the eustachian tube function is adequate, because that's the only outlet for the manipulated air pressure to leak. After the probe is sealing the extra-auditory canal, that's the only outlet. And ask the patient to repeatedly swallow. If with repeated swallow, the pressure comes back towards normal, that means your eustachian tube is good. It is equalizing the pressure. See, the function of the eustachian tube is to equalize the pressure in the middle ear with the outside atmosphere. So, with every swallow as the eustachian tube opens, it can equalize the pressure if it is functioning. And in 4-5 swallows, if it comes to near back to normal, that means your eustachian tube is perfect. So, one of the functional aspects you can overcome in the pre-operative assessment. And that's the surgical technique. I told you there is a middle ear cleft which needs to be addressed. It's not about mechanically repairing the tympanic membrane perforation. We need to look at the eustachian tube. If there is any mechanical obstruction, we need to look into the middle ear cleft for any adhesions, any other abnormal situation which requires to be dealt with, ossicular chain, and we need to confirm that the mastoid air cell system is being aerated down the eustachian tube on the table. If we assess all these three on the table and then graft, we may overcome all those hidden issues which can otherwise result in failure. That's the only thing which we can do to improve our results in tympanoplasty. Otherwise, we all are getting over 90% results. So this is a little bit more exercise to get better results. So I am starting the surgery for this patient. We have already done the post-oral incision. So quickly we'll discuss about the surgical steps. I'll request everybody to come out your suggestions, questions, whatever, to make it more and more interactive. And the next case, cochlear implant, will be after this tympanoplasty case. So anything else you want me to?
Sir, for the beginners, any key point regarding pediatric tympanoplasties?
See, age is no bar. As long as the nose and the eustachian tube issues are addressed. The reason behind this pediatric tympanoplasty, why did this question arise? The reason being the pediatric eustachian tube is most of the time compromised because of its anatomy and because of the possibility of recurrent URI in the pediatric patients. Their immune status is obviously not as perfect as adults. Their eustachian tube is not as angulated as adults. They have more issues like recurrent URI, adenoids and other things which can affect the eustachian tube function. So, in pediatric age group, they are likely to be, more and more affected by the eustachian tube problem. So, we tend to avoid them. So, if you are patient whom you are planning to do, and if you ensure that all those issues can be taken care of, you can do. Age is no bar. Similarly, for elderly, age is no bar. Is as good as for any age group patients.
Yes, sir.
But the dicta.
Surgery, sir?
Yes. So, in a couple of minutes, we will be back with the surgical picture. And Amit, we can continue discussion.
Yes, sir. Opening into the walls, like a lot of people are there. We will ask them if they have any queries, we will take it up.
Yeah. So, after 5 o'clock, then after this, we will be starting this cochlear implant one. Hello.
Yes, sir.
Yes, Amit.
Sure. Sir, started, okay.
Yeah, let me know when you get the microscope picture. I told you, I asked our associate to get this post-oral incision and all that, so we can
Yes, sir.
save some time
Yes, sir.
and focus on more core issues.
Sir.
So this post-oral incision was given and the margining fashioning was done. These are two things which have already been done to save a little more time for important issues. Can you see how the picture?
Yes, sir. Now it's clear.
Yes. See this, wash. See the void canal, good canal,
Yes, sir.
and you can even see the Eustachian tube area.
Yes,
See
sir.
there. We always flush this Eustachian tube in all cases. Many a times you get foreign bodies lows, sometimes the purulent discharge or anything which can plug the Eustachian tube.
Yes.
See, this is the subtotal perforation. You can see margins all around. Can you?
Yes, sir. Yes, sir.
So our proposed technique is interlay for the regions which has an edge over other techniques in such perforations.
Yes, sir.
The reason is, see, I am not criticizing the other techniques are not good, but there are certain disadvantages which we need to be, discussing. For underlay, if you do such a subtotal perforation, keeping the tympanic membrane graft underneath these narrow margins, small margins, is very difficult. Even you can do some tucking or something, additional incision entry, you can do that. But that may not maintain or sustain a sudden negative pressure in the post-operative period, and a graft may fall. This interlay means interposing the graft in between the layers of the tympanic membrane, which I am going to show you.
Satish, is the malleus seeming a little bit retracted?
Little
Space?
bit, little bit.
Not much. Not.
Yeah, there is space, circular.
There's space between the promontory and the.
Yeah, adequate space. Adequate space. See this?
Yeah. Okay. Okay.
And
Fine.
I am not of the opinion to cut this malleus majority of the time.
Yeah. If it is in the tip is embedded in the mucosa with the fibrous.
I would elevate, and I would rather prefer to cut the tendon rather than nipping the malleus now. The malleus has a good lever effect, we should not lose that. Now see, my incisions for this technique. I told you the core part of the technique is to dissect the tympanic membrane in between the layers and will
Yes, sir.
interpose or graft between the mucosal and the fibrous layer. The outer one is epithelial, then the fibrous and the mucosal, and will interpose or graft in between the layers. So we need to elevate exactly in between the layers. You should be able to see all the layers as a whole. So and this should be almost 360-degree elevation, because we have to go all around this perforation and beyond for additional tucking of our graft. So this is the posterior superior margin of the perforation. Can you see?
Yes, sir.
My incision is a few millimeters beyond this posterior superior margin. Can you see? This canal incision, few millimeter beyond the posterior superior margin, you can see.
Yes, sir.
And I can elevate a part of the tympanomeatal flap easily like this. Okay?
Yes, sir.
This is superiorly. Same thing you have to do inferiorly, but the issue is I have to elevate this entire flap circumferentially. See this? So ideally I should give an incision circumferentially like this.
Yes, sir.
If I give an incision so laterally, I need to elevate entire tympanomeatal flap down the annulus, and handling that would be little more cumbersome. So to make it easy, what we can do, I will make this incision little bit limited one. See, this is the inferior margin of the flap,
Yeah.
this one. My
Yes, sir.
inferior incision is few millimeters beyond that. See that?
Sir.
But not up to the level of the tympanic membrane. This is not a difficult technique, believe me. Everybody who has worked here has done this technique in numbers. See, simply you can raise the flap with the same principle, elevate it, bang on the bone, respect the flap, keep your suction behind your instrument so you don't damage it. This flap or epithelium is vital. See this?
Yes, sir.
This I have not extended till tympanic membrane level. See this?
Yes, sir.
And I have limited this incision medially a couple of millimeters lateral to the annulus because we have to go circumferentially.
Yes, sir.
And now I will make this incision circumferentially like this so that I can avoid elevating this unnecessarily. That would make otherwise the life of the surgeon cumbersome, which is not needed. Sometimes if you have a big hump, you can do that. You can elevate and drill the hump.
Sir.
So simply I am extending this and slowly elevating at all levels together to avoid tears in the flap. See this? And anteriorly I can go again beyond the margin. See this?
Yes, sir.
This is your anterior superior margin and I am going beyond that. I hope it is very, very clear to everybody.
Yes,
Yes,
sir.
yes.
See this? So my next goal is to elevate this flap all around together till the level of the annulus simultaneously so as to avoid the tear. See, this anterior flap is more thinner. You have to be little bit more careful while elevating the anterior one. The posterior one is relatively thicker. Anterior one is sometimes a single layer of epithelium. See, you can see the glimpse of the annulus anteriorly.
Very nicely, yes. Okay.
So this level of the annulus we have to reach everywhere simultaneously to avoid tears. See this. We have seen antero superiorly, now see anteriorly. See the annulus anteriorly?
Yes, yes.
Now antero inferiorly. Simple technique. If you execute properly, you can literally, give better results in certain situations. See this? Antero-inferiorly annulus.
Yes.
Sometimes you find a sharp ligament over here. Ashish,
Yeah, yeah, Satish.
many a time we call it Ashim Desai ligament,
Yes.
who has described many a time this ligament. Why this is important to discuss? Because that ligament, if you try to elevate with your blunt instrument, can result in tears in the flap. So you have to be careful and cutting it sharp. Ashim always emphasize it, and I call it Ashim Desai ligament. See, now I am coming inferiorly. See this?
Yes.
Goal is to reach the level of the annulus all around.
Hmm.
And now posteriorly. Feel free to interrupt me for
Yeah,
and
it's
it-
going well, Satish. Yeah.
see this posteriorly annulus
Yes.
everywhere.
Now,
Now,
yeah, yeah.
now if I reposite it, you can see like this, all around the annulus is exposed, and if I reposite, this is the same perforation.
One of the delegates wants to know if it would have been a small perforation in the posterior part, would still you have been doing the same technique?
Not really. See, practically in our practical scenario, we do variety of tympanoplasty, follow variety of tympanoplasty techniques. In small posterior perforation, this kind of surgery what I am doing is aimed at addressing subtotal perforations or large central perforations. In small posterior perforations, You can do simple underlay with some sort of tucking anteriorly or over underlay by means of involving the malleus for the support or inferior tucking or variety of, you have to ensure that your graft is well tucked. Not for all perforation, this technique is best suited for subtotal and large central perforations. Now, my next step, you see, you have seen the annulus.
Yes, sir.
My next step is to elevate the annulus out of the tympanic sulcus, bony sulcus. See the same circular knife, I have elevated the annulus. Can you see?
Yes, sir.
What you see, this underlying membrane? This is mucosa. Can you see?
Yes, sir.
So second step is elevate this annulus of the tympanic sulcus everywhere. If we follow judiciously, we can avoid all the tears. See this? In no time one can easily elevate this out of the sulcus. See this?
Yes, sir.
Everywhere you can see reflecting mucosal layer. Can you?
Yes, sir. Yes, sir.
And now posterior and posterior superiorly. The same thing. See this annulus?
Yes.
And is out of the sulcus. Okay?
Yes, sir.
Now the most important step, as I mentioned, we have to literally divide the tympanic membrane into layers. My next step would be to separate this mucosal layer below from rest of the two layers.
Yes, sir.
Again, focus on this. This is a very important step, very simple but yet need to be described. See this, my blunt angle. Can you see the instrument?
Yes, sir.
See this mucosal layer below. And I am doing separating the rest of the two layers from the mucosa. Can you see?
Yes, sir.
Without traumatizing the mucosa. Here the best thing is to separate off the mucosal layer, not to traumatize that. See this? This is the mucosal layer on which the graft is going to sit. What a superb bed for the graft it is going to be. And rest two layers will fall upon the graft. That's how the the graft is going to be interposed. See this? One can elevate simply without making any extra efforts. Can you see this? All the way.
Yes, sir.
The mucosa is a superb bed. One can literally divide the tympanic membrane into layers. This avoids any sort of blunting. This avoids any sort of epithelium leaving back. All the, disadvantages of only technique one can avoid. Here the graft is going to take the support of the mucosa. It is going to sit on the mucosa. So graft is not likely to be falling in any given situation. So that way you can avoid all the disadvantages of underlay technique.
इसमें बच गया वो posterior part हमेशा बचता नहीं है.
No, it is not divided, it is retracted. Sandeep?
I know.
See, this mucosa is what? What is this mucosa? It's the same mucosa which is lining the promontory. It's draping all around the middle ear walls and then coming underneath the tympanic membrane. See this?
Yes, sir.
Sandeep. Yeah, Sandeep.
Yes, sir. Sir, always sometimes the posterior in a larger perforation, the posterior mucosal layer is also missing something.
It is not missing, it retracts. See, this mucosal layer is a small layer and it can retract behind.
Yes, sir.
So it can just retract, which you are describing as a missing.
Yes, sir.
See now very well?
Yes, sir. So it doesn't be as prominent as the superior one.
Yeah. It depends upon the site and size of the perforation.
Yes, sir.
So all around what we have done, we have separated the mucosal from the of the layers.
Yes, sir. The pedicle of the flap is mostly at the head of malleus.
Yes, superiorly It doesn't matter sometime if it is free one. We do reverse interlay in cases where, you know, we have a perforation which is extremely superior involving all around the
Yes, sir.
malleus. We can elevate from here and keep it attached inferiorly, reverse. Here in this scenario, we have kept it attached superiorly. So the goal is,
Do we do chondroplasty for the anterior, if there's an anterior overhang?
most of the time we do not do. In case if the hump is too big to visualize the layers, then obviously you have to do it. But generally we try to avoid and, you know, doing canal plasty in every case.
Yes, sir.
See now, I have reposited the tympanomeatal flap back. Can you see?
Yes.
Like it was not elevated at all. Now see, if I elevate, the difference is the mucosal layer is left below, you can see all the way,
Yes. Yes.
and rest of the two layers have been elevated. Can you see everybody?
Yes, sir.
All around. See this? Mucosal layer is left below. Can you see everybody?
Yes, sir. Mucosal bed for the graft to rest.
Yes. So my graft is going to sit on that mucosa in the canal, so as to prevent, you know, or sustain any sort of negative pressure which can draw the graft medially, which can happen in underlay technique if that happens in the immediate post-op. So that is the additional security. And my graft is going to remain in the most physiological position. Physiological means between the mucosa and the epithelial layer. The graft is a fibrous tissue which is supposed to be in between the mucosa and the fibrous layer, and where it is going to be. See this?
Yes.
See, this is the, you know, flap elevation part. And now ossicular chain. Can you see the glimpse of the incus behind?
Sir, there's a delicate question. They're
Yeah.
asking if there's a tear in the flap, what should we do?
You have to go beyond, overcome this.
In the mucosal layer, in the mucosal layer, if there's a tear, what should we do?
Yeah, mucosal layer, if it is torn, you can cut the edges again till the level of the tears. You can see like the less mucosa is there rather than hanging down. So remove the torn part, because this mucosa is same which is coming from the middle layer, then draping along the walls and then coming underneath the tympanic membrane.
Yes.
You don't bother about that. Now see, this is the ossicular chain if you see.
Sir,
And see what I am doing simply.
let's see. Checking the continuity.
See the mobility of the incus and the stapes.
Yes.
Very well.
Yes, sir.
And you can see even the glimpse of the round window, so prominent.
Yes, sir.
So we have seen the middle ear flap, we have raised the flap, we have seen the ossicular chain, we have flushed the eustachian tube area, and all look perfect, and the bed for the grafting is ready. Before grafting, what all left is assessing the mastoid air cell ventilation down the eustachian tube. We can assume in the dry air that the editors must be, open to ventilate the air cells in the dry air, but not always. We have seen this editor's blockage even in the long-standing dry years. And that is one thing which can have a negative impact on the outcome if it is left unaddressed. So how to confirm this on the table? See, radiologically people say if there is a good pneumatization of the mastoid air cell, means they are being aerated. That is one indirect sign. Another indirect sign is if you do your endoscopy. Nowadays the autoendoscopy is prevalent. If you do endoscopy with a 45 degree or anything, you see the editors from inside. That is again an indirect idea that editors must be open from outside as well. But many a time they all can prove wrong. We have seen adhesions from the mastoid side. We have seen tympanous sclerosis, mucosal flux beyond the level of visualization of the endoscope from inside. So the best test what we do, this is the test, is checking the patency of the mastoid air cells down the Eustachian tube on the table. So this is a test, not a sort of cortical mastectomy or anything I am doing. The moment I find the patency, I will stop. I am not doing a classical cortical mastectomy or enterostomy or anything. I am not doing enterostomy. My goal is not to open the antrum from here. My goal is to check the patency. So the same principles you have to follow. Enlarge laterally before going deeper. The moment I get the patency, I will stop. See now?
Yes, sir.
Can you see the patency?
Yes, sir.
This is Ice-Gola test.
Eyes go.
This name was given by Ashish Bhumkar.
He's sitting right next to me.
Yeah. He calls it Ice-Gola test. See now. Free flow. See, I have not reached the level of the annulus. I have not reached the level of the antrum. What I found is my mastoid air cells are being aerated down the Eustachian tube. Can you see very well?
Yes, sir.
And I need not to go deeper unnecessarily to dissect anything or to complete enterostomy or to cortical mastectomy. So this is a test, mind it. There should be no confusion. I am not recommending cortical mastectomy or anything for every case. This is my direct confirmation, on the table confirmation of patency of the mastoid air cells down the Eustachian tube. We can do indirectly by radiology or by endoscopy, but that can prove wrong. And we have found that proving wrong. So this is the test. It doesn't take more than a minute. See, in dry ears, how long did it take? Not more than a minute. We just found the patency so laterally. Once you found the patency, at least you can be 100% sure now that you have checked the entire medullary cleft. The goal is to address the entire medullary cleft, which I told in the beginning. Now my bed is ready for the grafting. Can you see?
Yes, sir.
And immediately after this, we'll be starting the cochlear implant case. Cotton ball. So now, for the graft, we have not harvested the graft yet. We now believe in fresh grafting, or what I call it, bed-to-bed grafting, which I am going to show you. I don't want to damage the fibroblast of the temporalis fascia to make it more and more atraumatic. Though we have seen the grafts do take up, even if you dry up, even if you make them dry by any means, by lamp or anything, still they work, because they most of the time act as a scaffold. But in any given situation, this fresh graft cannot be inferior to that. Rather than going into discussion that it is needed or not, I would say it is never inferior to that. And but what we have found in our practice, the healing is much faster than the dry graft. Can you see the fascia graft?
Yes, sir.
See, this is true fascia. This layer which I have separated, this is innominate fascia. There are variety of layers in this region, and this is innominate fascia which I am separating. See this? And underneath, this is the muscle. Underneath, you can see the vessels of the muscles underneath the graft. Through the graft, you can see. So our goal is not to take the innominate fascia, not to take muscle or any additional tissue, because this graft is going to be a free graft. This is not a vascularized graft. It has to sustain the metabolism unless it is vascularized. So it has been believed, we all know, that the fascia has the minimal metabolic requirement. So I am harvesting the true temporalis fascia graft. This is always we propose. See this? The dimension of the graft, according to the experience, you can, measure on the table, rather than doing any XYZ thing beyond afterwards. So this is the size of the graph which I am going to use in this particular scenario. See this? The true fascia graft. Can you see? See the underlying muscle pretty intact. If you damage the muscle fiber, sometimes we see our patient complain of, some pain or some funny sensation post surgery. That is purely because of the damage to the muscle, over cauterization or whatever. So, and we should give a special attention to it, not to raise anything except the graft. This is pure temporalis fascia graft. Can you see?
Yes, sir. So
I
we should take a longer graph comparative to a regular underlay case.
No, not longer. The graft size is little bigger because this has to be on the canal wall all the sides.
Yes, sir.
All
And
around.
we have to again pull it from.
I see the vessels inside the muscle.
Yes.
Ashish Bhumkar does variety of vascular flaps in this region for his atresia surgery. He is known for, popular in the world for his pinna reconstruction and atresia surgery. Yeah, so he does variety of, graft to vascularize that area, and the temporoparietal fascia graft is one of them. See my graft there, I have elevated from there and placed here another bed. Can you see? And I believe Ashish is still using temporoparietal fascia grafts, flaps.
Yes, Satish. Yeah.
So that is amazing. I have seen him using the Doppler to find the vessel and elevating the temporoparietal fascia graft. That is a beauty which we have to learn from him. Temporoparietal fascia is one of the versatile flaps for many reasons. He uses for pinna reconstruction atresia. We use for many other reasons, for lining of the temporal bone defects, for partial obliteration, and even for reconstruction in the oral cavity post cancer surgery. We have used couple of times. So that you can take down inside the oral cavity as well. Now see, our graft bed is ready to accept this graft, and this graft I have elevated from the bed. I am going to place to another bed. Can you see?
Yes, sir.
This is fresh graft. That's the beauty of the fresh graft. Believe me, this is much easier to handle. Lot of people tell me that this would be difficult to handle than a dry graft.
Side of the graph is important, sir. Which side you have to face?
Yeah, I do it upside down. The raw area facing the under surface more and more. The both sides are raw, but see this? The first part, I explain our junior colleagues this grafting in 3 phases. Number 1, what I am doing is introduction of the graft all the way in the middle anteriorly. See this? This is simple introduction.
Sir, he joined us. Dr. Ashok.
Hi, the otologist.
Hey, bro.
Hi, boss. I mentioned in the...
Wait, I feel I should relearn pathology.
No way. There I have not seen any otologists, on the planet than what you do. I mentioned in the beginning, the surgery what I am doing is one which I learned in 90s from the ABR Desai. See this fresh graft, boss.
Yeah, man.
So my grafting is in 3 phases. One phase, the first phase is over now. What I have done is introduction of the graft in the middle ear. Can you see?
Yeah.
Pushed it far anteriorly. This is a large central subtotal perforation, boss.
Yes.
And see, I have pushed the graft underneath the malleus. Can you see?
Yep.
Very
It's
clear.
very important to go below the malleus.
And
to maintain.
I have spread it on the edge to edge in the canal. This is my first part. My second part of the grafting is to replace the tympanomeatal flap posteriorly and inferiorly. See this?
Yes.
This flap is going to come above and the mucosal layer is below, we have seen. So this graft is literally sandwiched between these 2 layers, and I will make it, one surface. See, by surface tension, These surfaces come to each other. See this? The graft and the flap.
Yep.
They take on each other. This is the second part, and in this I elevate whatever the graft we have pushed. See this? I will elevate it over the mucosa. See, the simplest. The first part is advancing into the middle ear. Second part is the posterior part joining with the flap, and the rest of the fascia is placed over the mucosa. Why this posterior part joining the flap? So the graft is not displaced posteriorly. See
This
this?
is a very important part of leaving the mucosa medial to the graft, because the fundamental issue of myelinitis is it's an aseptic myelinitis that occurs due to mucosal overgrowth in the
Yes.
classic underlay.
Yes.
So the way forward is to make sure that the mucosa is totally stripped from the fibrous layer and remains in the middle ear, and then you don't need to undergo total annular excision, so on and so forth.
Yes. Now see, I am replacing the rest of the tympanomeatal flap over it.
Yes.
See all around. This is second part. See now, and you can see the cone of the light from the umbo.
Correct. You already have a light reflex.
Yes. This is second part. Now the third part of the grafting is to ensure 360 that my graft is lying in between the mucosa and the rest of the two layers. I am checking whether this sandwich is in order or not.
Yes.
See this, posterior superiorly it is in order, posteriorly it is in order.
Yep.
Sir, anterior superiorly should be overcorrected?
Not really. I have mentioned in the beginning that I have raised my flap beyond the anterior superior margin of perforation to place this graft beyond the margin of perforation.
Yes.
I will show it again, Sandeep.
Yes.
Now inferiorly again to check. You have to ensure that this sandwich remains in order all the way. See inferiorly.
The beauty is check, recheck, and recheck.
Sometimes your dry graft doesn't allow this ability. That's why I love this fresh graft. It follows your orders. Much better. See this? Your graft is sitting on the mucosa.
Everything follows your orders.
None of us. It depends how you are used to. So this is why I always propagate, because the dry graft.
You are placing the annulus back in the sulcus. Right?
Yes, yes. See this? Annulus back in the sulcus. So we have seen this inferiorly as well. You can see inferiorly. My graft is on the mucosa. Can you see the mucosal layer below?
Very well seen, Satish.
Yeah, and graft is on the mucosa.
Once he places the graft, I'm going to draw your attention to the air cells he has opened. You will start seeing the fluid movement, which is a perfect. Yes.
Yeah, that's a very important part.
Once
Ashish,
he
you
touches
notice.
that, you will indirect evidence that it is a airtight.
Now coming anteriorly and anterior superiorly is the same thing. See my graft, I'll make one unit with the flap. See my mucosal layer below.
Yes, sir. Yes.
And this graft is going to sit on the mucosa without any tension. We don't want this grafting to be anyway under any tension. This is anterior superiorly, this is anteriorly, everywhere, and my, see this? The graft, the flap is coming over it. Can you see everywhere?
Yeah.
Yes, sir. Most physiologically placed graft.
Yeah, the physiologically in the sense it is between the epithelium layer above, see this, and the mucosal layer below.
Yes, sir. Absolutely. And you even angling it like the.
And see, there is no support in the middle ear needed. Once you have compressed in the periphery all around in the place with all these layers. See all these layers in place?
Absolutely.
And no middle ear, no gel form or anything which is, which may interfere with the aeration. Nothing is required, no support is required at all. And I am tightening all around like we tighten the tennis racket from the periphery.
Yes, sir.
So this graft remains absolutely tension free right on the annulus. See this, I am pressing into the annulus. This is a fresh graft. You can see the color of the graft. See the anterior superior margin.
Yes.
Nowhere graft is, under tension. See this is.
Yeah, absolutely. And always we put a little bit of suction right anterior superior to make sure that there is no hidden lack, hidden deficiency causing an
Yeah.
residue.
This is what Ashish was saying.
Yes,
See the movement in the graft.
absolutely.
See this?
Yes, yeah.
Ashish,
Yeah,
Yeah, Satish, correct.
that's the important point you noted. And this entire graft, you can again see the middle ear space very nicely. See this? Nowhere in the middle ear this is needing any support. Nowhere. The support is all around at the periphery, you can see. Can you?
Yes, very nice. Beautiful, Satish.
So more and more support on the periphery keep the graft in place. See this? Now my next support at the periphery would come from the gel foam, which I am going to place at the periphery to bolster this sandwich. Sandwich is medially epithelium, medially mucosa, in between the graft, and over that the rest of the two layers. So I will bolster that sandwich by means of keeping these antibiotic steroid impregnated gel foams.
Satish, I have started using PRP.
Yes, even I have
It's
done.
helping, yeah, and it's giving me much better results than plain antibiotic steroid.
Yeah.
So I put steroid with PRP, the way you recommended.
Yes, even we discussed a lot about it. We do it.
Yeah.
PRP we use for many other indications also. See this?
Absolutely. It's a wonderful product, autologous, never to worry. All you need is a centrifuge which doesn't cost much. And you are better assured of rapid epithelialization.
Yes, because it contains growth factors.
Exactly.
It is just simply from the patient's own, plasma.
I learned it from you only.
I remember we did a workshop on that. Many times we discuss about that.
Sir, should we soak the blood, gel foam in blood also?
Yes. See, it automatically gets soaked in the blood in the region. The region for soaking in the blood is to contain, as the blood contains fibrin, to make it more and more adhesive. See this? So first on the periphery all around.
You're using the solution to soak the gel foam.
See this? First
Not the layer that you get like a graft.
yeah. See this? First on the periphery all around. So my graft remains displaced. This one technique, this was the first surgery I watched ABR Desai operate in my life. And that was something like my dream come true that day when I watched him operate in his own theater. And this is,
I saw his stapes first. And
yes,
I saw him drill the posterior, the shoulder of the posterior crus as he would call it.
yeah. And he would every time do intraoperative audiometry after placing this graft. Even in tympanoplasty, not in stapes surgery only, even in tympanoplasty, he would do
Hashim
intraoperative.
does it, I think now.
Hashim does.
No, stapedotomy he does. Yes.
He would
Vesicular
do.
plug.
Yeah, he would do in every case. And if he is even little bit dissatisfied with the hearing, he would remove everything, reassess everything. He will never mind spending more and more extra time to improve that. That is what his philosophy. And that day he called me, Satish, if you have to catch a flight or train, don't operate that day. You have to be committed. See this. This is what you can do. So this is simply the beginning of this prestigious conference, this live surgical session with one of the, I would say, the commonest, we call it the basic surgery, the most commonly performed surgery in otolaryngology, that is tympanoplasty. And we still, look for the better and better results by overcoming all the disadvantages by other techniques or the prevailing techniques. So still we strive to do more and more better for better results.
Satish, if you had to do a lot of canal plasty,
Yeah.
would you consider placing Celastic in the external auditory canal?
वो माइक चलवाना. In the extraordinary canal, see boss, I never place the silastic for the reasons I tell you in the extraordinary canal, and less in the middle ear nowadays.
No, forget the middle ear. Now it's lesser and lesser.
Yeah.
But if you had an extensive drilling, stenotic canal.
I am not of the opinion of doing extensive drilling for the reason I tell you. This extraordinary canal bone is unique in terms of containing the vessels coming out through this bone to supply our tympanomeatal flap. How our tympanomeatal flap is, supplied by. Many a times, even if you make it free and replace it back, it works. There is no direct vascularity over it. It is the Haversian system of the bone which, through which the vessels come onto the graft in the flap.
Correct.
So,
I am strongly against that vascular strip. It cannot possibly, the plastic surgery principle says it cannot possibly supply the blood vessels for the entire rim.
yes. So, in canal plasty, if you do with a diamond burr, lot of drilling, you end up, what does a diamond burr do? We use it actively to clog any vessels. If there is any bleeding into the bone, you can do diamond burr. Clogging of the, the bony canal by means of the bone. Whatever bone does, it removes, the diamond burr removes. So, this canal plasty, purposely, I would say, it clogs all the vessels underneath the bone where you do. So, in cases where the canal plasty is required, we try to do as limited as possible. We don't want to clog all those vessels coming from there by drilling the diamond burr all the way. Yes, if limited drilling is required, we do. Some cases, more and more drilling is required in cases of more and more narrow canal like you are asking. You have to do it. Sometimes it is unavoidable, but you have to do it. But we never use silastic for that. You use silastic there?
Yeah, I do. If there is extensive drilling, very schematic canal or narrow canal, I won't use silastic. I use 0.25, not 0.05, but 0.25.
0.25, huh?
Yeah.
Great. So now, any questions before?
Also use the post-oral skin. You see me use it anytime.
Yeah, वो था ना.
Mostly anteriorly, canaloplasty you get away by just tilting the head a bit. That is true.
Yeah. So now, before we move on to the next case, any questions from the audience or any suggestions or anything anybody does differently, because tympanoplasty is one thing which is still practiced by many people by many techniques. I know hundreds of techniques are prevalent. A lot of people are using cartilage, people are using overlay, underlay, over-underlay, this, that, variety of flap making and all that, and in their hands must be doing good results. I believe every technique give good results.
After we train with you, which become a standard for us to do the same technique.
I know Sandeep has done hundreds and hundreds of internal tympanoplasty over here in Jaipur, and he is extremely good surgeon. He has done many of our private cases as well, and at times I would not even look into what he is doing. He was so confident. Thank you, Sandeep.
Thank you, sir.